Welcome to episode 19 of the Pro PA podcast. I'm your host, Prof G, and today we're continuing our pulmonary neoplasm series with a clinical medicine brief on pulmonary nodules. Pulmonary nodules are a high-yield topic for both PANCE and clinical practice. And on this episode, we'll focus on the basics of differentiating between benign and malignant nodules, the evaluation and imaging pearls, and key management strategies with follow-up recommendations. As always, we'll wrap up with vignette-style questions to reinforce what you've learned. Let's dive in. All right, so let's start off with the Kinderpatho. What is a pulmonary nodule? Well, the definition of a pulmonary nodule is a rounded lesion or coin lesion less than or equal to 3 centimeters in diameter found in the lung parenchyma. So found within the lung tissue. Nodules greater than 3 centimeters are generally considered masses and they're more likely to be malignant. Nodules are typically asymptomatic and they're often discovered incidentally on chest imaging when chest x-rays are done for other reasons. So basically, a pulmonary nodule can form from either benign causes like infection, inflammation, or scarring, or they can be malignant processes like primary or metastatic cancer. The key challenge in clinical practice is differentiating between benign and malignant nodules, and we will look at that a little bit further here. So first off, let's look at the benign nodules. So benign nodules, the most common causes we're going to see are granulomatous infections like histoplasmosis or tuberculosis. We can also see benign tumors like a hamartoma, and we can also see benign nodules in inflammatory conditions like rheumatoid nodules or Wegener's granulomatosis. Imaging features of a benign nodule are typically that they look smooth and well defined along their edges. They usually have central calcification or popcorn calcification, as it's called. And this is an example of like a hamartoma. And they are usually stable over time, meaning that they are not rapidly growing. So we don't tend to see much growth over a 2-year period of time. Now, in contrast, malignant nodules, the causes are typically primary lung cancers like the ones we've talked about in our previous episode, adenocarcinoma, squamous cell carcinoma, etc., and metastases from extrapulmonary cancers like breast cancer, colon, or melanoma. So, imaging features of a malignant nodule look a little different than the benign one. So, malignant usually has a spiculated or irregular border. They also have eccentric or stippled calcification within the nodule, and the size tends to be bigger, greater than 2 centimeters, or rapid growth, meaning that they are doubling in size between 1 and 6 months. So these are some key findings for a malignant nodule. Now let's talk about clinical presentation. Like we mentioned before, most nodules are asymptomatic, and we often find these nodules incidentally when we do x-rays for other reasons. Symptomatic nodules may present with a cough, hemoptysis, or systemic signs like weight loss if it is a malignant nodule. The patient history usually contains smoking history or some sort of occupational exposure like asbestos. And travel history can indicate some sort of travel to an endemic area for fungal infections, such as the Ohio River Valley for histoplasmosis. And we can also look for a history of cancer, whether it be a personal or a family history, as a risk for metastases. All right, so how do we work up these type of patients? Well, initially, imaging is going to be the key thing. So a chest x-ray is often the first imaging modality where nodules are identified. Like we mentioned before a couple times, is usually found incidentally on accident. The next thing that we would want to look at, and actually the gold standard for characterizing the size, shape, borders, and calcification pattern, is going to be a CT scan. And not just any CT scan, this is going to be a high resolution CT scan. So, one of the major things that I want to impress on y'all is that we have to compare. If we find this new nodule on an x ray or CT scan, we need to compare it to previous imaging. So you always want to look and see if they have had any prior imaging when it is available, whether it be chest x-ray or CT. Look in their history, look in their records, see if you can find a previous imaging study. This will be really, really crucial because you can actually compare the current imaging study that you're doing to the prior imaging to look for whether that nodule was there prior, whether it's grown. It really will give you a lot of information. So, stability, no growth over 2 years, is highly suggestive of a benign nodule, whereas growth or changes in morphology can raise concern for malignant and warrant further investigation. The next thing we're going to want to do is risk stratify. So, we want to differentiate between those nodules that are low risk and those that are higher risk. So, low risk nodules tend to happen in younger patients, so less than 30 years old, in non smokers, and in stable nodules, so less than 6 millimeters and stable, meaning they haven't really grown if they have been present for a longer period of time. A high risk lesion or high risk nodule would be in patients greater than 30 to 50 years old, a smoker, a history of malignancy, or a spiculated nodule greater than 2 centimeters. Now, let's look at the follow up recommendations. So, if we find a nodule that is equal to or less than 6 millimeters in size in a low risk patient, we do not really have to follow them up. If we have a patient that has a nodule that is greater than 6 millimeters, we should continue CT surveillance at intervals based on the size and the growth pattern. And in most cases, this is followed up with a pulmonology referral. So we're going to want to send these patients to the specialist to have that nodule monitored. Further testing that can be done, well, we can do PET scans. This will evaluate the metabolic activity. So malignant nodules tend to have a higher glucose uptake and they tend to light up on a PET scan. Another thing we can do is if we can access the nodule, we can do a biopsy. So again, for a more central nodule, we can do a bronchoscopy to remove a little piece and send it off for pathology. Or if it's more peripheral, we can do a transthoracic needle biopsy. So let's look at the overview one more time. Management. Benign nodules, observation with serial CT scans to monitor for growth changes in morphology, and treat the underlying infection or inflammation if that's what it is. If we are suspicious for a malignant nodule, we want to attempt to refer for further imaging, get a biopsy, and if necessary, a surgical resection, whether it be a lobectomy or a wedge resection in early stage lung cancer. And definitely, if the patient is a candidate for chemo or radiation, we want to refer for oncology so that they can look at the options for the patient. Some clinical pearls: compare, compare, compare. So, previous imaging is a critical step in assessing for stability of growth in a pulmonary nodule. Size also really matters. So, nodules greater than 2 centimeters are much more likely to be malignant and need to be further investigated. A smoking history is a red flag. So, we always need to assess for smoking and environmental exposures when we are evaluating pulmonary nodules. And last up on my clinical pearls is a PET scan pitfall. False positives can occur with infections or inflammatory conditions, so a biopsy is critical for definitive diagnosis. The last thing you want to do is tell a patient they are dying of lung cancer and it's just an infection, right? Okay, so now that we've gone through some of the ins and outs of pulmonary nodules, let's look at some questions. Question one: a 58-year-old male with a 30-pack year smoking history has a 1.5 centimeter spiculated nodule on a CT scan. A PET scan shows high metabolic activity. What is the next best step? Is it A, repeat a CT in 6 months? B, perform a transthoracic needle biopsy? C, start empiric antibiotics? Or D, refer for surgical resection? I'll give you a few seconds. If you said B, perform a transthoracic needle biopsy, you are correct. So the combination of a spiculated nodule, a PET positive findings, and the smoking history is highly suspicious for malignancy. So the first step in this would be to get a biopsy, and this is necessary for tissue diagnosis. All right, question two. A 45-year-old non-smoker has a 4 millimeter smooth, well-defined nodule on CT scan. There's no history of prior malignancy or symptoms, what is the best management? Is it A, follow up with the CT in 3 months, B, perform a PET scan, C, no follow up needed, or D, biopsy the lesion? I'll give you a few seconds. If you said C, no follow up needed, you are correct. Per the guidelines, nodules less than or equal to 6 millimeters in low risk patients do not require follow up. All right, I want to thank you for tuning into this episode of the Pro PA podcast. I hope this clinical medicine brief clarified the essentials of evaluating and managing pulmonary nodules, especially the importance of comparing with previous imaging. Stay tuned for our next episode where we'll cover carcinoid syndrome, the final topic in our pulmonary neoplasm series. If you found this episode helpful, please follow the podcast and hit the notification bell to stay updated. And remember, this is the Pro PA podcast, where future pros in medicine are made. I'll catch you soon.